At the outset, I would like to thank the AIOS, and it's wonderful to be back here in a physical setting rather than just online where you can't really interact. So I think this is my second talk after the thing has started. So I'm going to talk today on cataract and epiretinal membrane and macular hole. So it's important that we have a high index of suspicion whenever we see such patients. Whenever there's a mismatch between the grade of cataract and the visual acuity, one has to be sure that there is nothing wrong with the macula. So you have to see importance of symptoms of central scotoma and metamorphopsia. There are some patients who have cataract but they still complain of metamorphopsia, and in these patients you must do a pre-op OCT. You can also do a slit lamp biomicroscopy with a non-contact or a contact lens. There's a Watzke-Allen test. However, the OCT takes preference over all these things, and most of these patients have to be subjected to a OCT pre-cataract surgery. Now, if you see on the OCT, there is a progression of the holes which are there. However, lamellar macular hole can remain stable over a period of years, and nothing sometimes may need to be done. Sometimes there are epiretinal membranes which are found on a routine examination, and even in these patients, the patient's vision is good. So again, nothing needs to be done. So when we see these patients, you have to assess the degree of the macular hole or the epiretinal membrane. One has to see whether there's progressive visual loss, which is accompanied by worsening of the hole or worsening of the macular edema. Lamellar holes usually do not progress. Full thickness holes usually have to be operated. If there's increasing macular thickness with traction, then definitely the ERM also needs surgery. And it's very important that you rule out other causes like parafoveal telangiectasia, diabetic macular edema, and CNVMs. Because sometimes through a cataract, your fundus view may be hazy, and one needs to do OCT and sometimes even a FFA if they get some good pictures in order to differentiate between these conditions. The next thing is you need to assess the degree of cataract. The most important question is, does the cataract need surgery if there was no hole? And is visualization good enough for an ILM peel? Once you assess this, then you decide what to do. There are three options. You can do cataract surgery first and macular surgery later. You can do cataract and macular surgery both at the same time. Or in patients in whom you can see enough to do an ILM peel, you can do the macular surgery first and then do the cataract surgery. Let's see about each of these things. Cataract first and then macular surgery. If there's doubt about the status of the hole, sometimes you have a small lamellar hole, the patient doesn't need surgery. Patient has significant cataract, go ahead and do the cataract surgery. In a lamellar hole, cataract surgery would improve the vision. ERM patients who do not have thickened macula or traction again will improve with the cataract surgery only. And sometimes patients are unwilling for retinal surgery. They have heard that retinal surgery is very difficult, you need to keep your head down, etc., and they just want cataract surgery, see how much the vision improves. But in all these patients, you have to say that we will have to do the surgery in 2 sittings. First stage, do the cataract, and then if required, do the macular surgery also. Here you see a patient who had significant cataract. However, there's a small outer lamellar hole over here. Patient doesn't need to undergo macular surgery. We do only the cataract surgery. Look at this patient. This patient was advised a combined surgery in one of the big institutes. And when we saw her, there was a little epiretinal membrane. I thought that the patient would not need a retinal surgery. This is 2017 picture. This is 2020 picture. We did only the cataract. The ERM is absolutely stable. Patient's vision has improved from 6/18 to 6/6 partial N6. Patient is an 80-year-old housewife. Patient is happy without doing the retinal surgery. So if you feel at any stage that if you only do the cataract and the patient's vision would improve, do the cataract only. The next thing is single sitting cataract and macular surgery. This is essential if an ILM peel cannot be done. If the degree of cataract is so much that you can't do ILM peel, you will do it. It reduces the surgical time. There's a faster visual rehabilitation. However, wound leak chances are increased with prone positioning. There are monetary and insurance issues. Whenever you do a combined surgery, you give the bill for cataract with a vitrectomy, the patient always gets reimbursed only for cataract, and that to a very minuscule amount. So this is the problem which we have with insurance patients. There's also an ethical dilemma. Your cataract surgeon colleague has referred the patient to you. Should you be doing both the surgeries, or should we refer the cataract surgery back to him? So this is the ethical dilemma which we face in private practice. So when you do combined surgery, you always do the cataract first. You have to avoid corneal edema, miosis, any air bubbles in the viscoelastic. So at all times, you should have a good view of the retina. You also avoid multifocal IOLs, and you ensure a good watertight closure of the wounds, because afterwards the patient has to lie in the prone position. In the post-op period, wound leaks are common. There is more inflammation in these patients. Like sometimes there's a small streak of blood on the corneal endothelium. Because of the air bubble, the IOL can get displaced, and dilatation may not be possible in the initial stage of the disease because you have put a lens also. However, multiple studies do not show any increase in hole closure rates or complications, but visual rehabilitation is definitely faster in combined surgery. Then you do macular surgery first and then sequential cataract surgery. This can be done only if ILM peel is possible, which means that the cataract is very minimal. The patient is not willing for cataract surgery. Sometimes you have a young patient, a 40, 50-year-old patient with a macular problem. Why do you need to do a cataract surgery at the same time? Head-down positioning is safer and there are lesser chances of wound leaks. There's a better chance accuracy of biometry. If there's a macular edema, a significant edema, your biometry can go wrong. So once the edema settles down, your biometry is better. Again, you have monetary and insurance issues because you're going to doing one surgery, then doing the second surgery. In the second surgery, there would be zonular compromise because now you're doing surgery in a vitrectomized eye. Sometimes it has been reported that macular edema post-cataract can open up the hole, and there's always a posterior capsular plaque. So in sequential cataract with vitrectomized surgeries, there's a very dense cataract, and often a dense brown nucleus, just 2 minutes. There can be zonular compromise, anterior chamber fluctuations, lack of vitreous support, and a higher chances of fluid misdirection. In all these patients, there is a posterior capsular plaque, and you always need to warn the patient about it because after the cataract surgery, the vision will not improve. You may need to do a YAG laser later on. I just skip this. And so there is a large study which has come in ophthalmology retina in November 2021, in which they compared combined versus sequential phacoemulsification, and there was no difference in post-op best corrected visual acuity. The combined surgery had more fibrin and synechiae and intraop and post-operative retinal detachment. However, there was a lower incidence of posterior capsular tear and macular hole non-closure or reopening. So with this, the jury is out. You can do either of these things, whichever you are comfortable. They all give rise to approximately the same result. Thank you.
Questions to Ashish? I think a monetary issue is important because if you do together, then एक का पूरा मिलता है, एक का half मिलता है.
Yeah, exactly. That's what. So that is very important.
And if you are doing ERMP later on, the person has had a cataract surgery, patient's vision has improved, patient may not require, as you rightly pointed out.
But there are patients, especially younger patients with, like you were showing one case where that 80-year-old lady, suppose you have a traction and then many of these patients complain of metamorphopsia, post-cataract surgery.
Definitely.
So that could be an indication for...
Yeah, so in these patients, you have to warn the patient that you will need a sequential surgery. Yeah. And also in these patients, I think you need to wait for if you feel the edema is not significant initially, you need to wait for 2 to 3 months for the post-operative edema to settle down. So only after the post-operative edema settles down, you will be in a position to judge as to how good the vision is.
Very true.